First of all, thank you for being here today. Welcome to the NF Knowledge series for the month of April. This is a fairly new monthly educational webinar series that CTF has created for patients and families and loved ones of those who are impacted by NF of any kind. My name is Kate. I work with CTF in patient education and engagement, and I'll be your host for today's webinar. Closed captions are available. If you click on the CC button at the bottom of your screen, we have a live captioner here today. And we are going to be recording this event. So if you have to leave early or you know of folks who registered but couldn't attend, it'll be fully recorded and made available publicly through CTF's YouTube site. So look for that. And then also in today's webinar, there is a button at the bottom of your screen that says Q&A. If you could use that to ask any questions at any point during our presentation, we will use that to then do a live Q&A with our speaker after at the conclusion of his talk. So please use that for your questions. You're welcome to say hello in the chat and let us know where you're signing in from today or what your connection is to CTF or to NF2-related Schwannomatosis. We would love to say hi to some of you. We've got a lot of CTF staff here today, some of whom you might know, so feel free to say hello. So all of that, I'm very excited to actually hand things over to our speaker today. I'm very pleased to welcome Dr. Oliver Adunka, who is probably well known to many in this community. Dr. Adunka is the William H. Saunders Endowed Professor and Vice Chair for Clinical Operations in the Department of Otolaryngology and Head and Neck Surgery at The Ohio State University. He also serves as the director of the Division for Otology, Neurotology, and Cranial Base Surgery in that department, and directs the Pediatric Otology and Hearing Program at Nationwide Children's Hospital, which is one of the largest institutions of its kind, which is fantastic. And I know we have a lot of folks who are seen there and cared for by Dr. Adunka, who is also, I have to say, a committed advocate for this community. We're very grateful for his time, as he also has served as a member of CTF's Clinical Care Advisory Board since 2026. So very, very happy to have you here, Dr. Adunka. And with that said, I'm going to go ahead and hand things over to you. Let me just get you pinned there, spotlight. There you go.
Yeah, thank you, Kate. Thanks, everyone. Let me start by sharing my screen here. Kate, is this the correct
right.
one? Can you see
great.
that?
Yeah,
okay,
we're just seeing your slide. That's perfect.
Awesome. So technology is good. So
yes.
That's always a first hurdle. Yeah. So thanks everyone for joining today, and for those of who of course watching it via the YouTube channel. A hi to everyone. It's an honor to speak to all of you, and so the topic for today is to talk a little bit about how we manage hearing loss and how do we really preserve hearing for the longest possible time in folks who have, again, schwannomatosis, NF2-related schwannomatosis, so neurofibromatosis type 2. Here are my disclosures. Really, none of those are relevant for today's talk, but wanted to get those up here. So really, today, really about management of vestibular schwannomas. I'd like to talk a little bit about management, how we manage sporadic vestibular schwannomas and hearing, and what the difference are for us as providers with managing against tumors that are not due to NF2, and because I think it's really important to understand the differences that we face and patients face. Hearing preservation, then some of emerging medical therapies. Again, I'm not a neuro-oncologist. I don't really handle a lot of these drugs. So, but how we view them as surgeons, really, the importance of these other non surgical treatments, and then we can draw some conclusions from all this. And please feel free to put your questions in the chat. The very last slide, I have my email, so feel free to reach out if you guys have any questions. And depending on where you live in the country, I can either help personally or get you connected with someone in the region. So again, with NF2-related schwannomatosis, bilateral vestibular schwannomas are by far the most common presentation. We see it here in 90 to 95%, right? A lot of folks have other cranial nerve schwannomas, as indicated here. As we all know, meningiomas and other tumors are also prevalent. But again, 90 to 95% of folks have vestibular schwannomas. Again, the former term was acoustic tumors. The more accurate term really vestibular schwannomas, because they take an origin from the balance nerves, from one of the two balance nerves behind the ear in the internal auditory canal. Here's some other presenting symptoms of NF2. Really, topic for today, for today's talk, is really those bilateral vestibular schwannomas that we will focus on. In general, again, there are acoustic tumors, acoustic schwannomas. There are several other terms that folks are using. Again, vestibular schwannoma is the correct nomenclature. It's a benign intracranial tumor. It either takes its origin from, again, the superior or the inferior vestibular nerve. Those are the balance nerves, again, that connect the ear and the central nervous system, so the brainstem, essentially. And if you look at the literature, roughly 50% of tumors originate from one or the other. It accounts for about 6% of all intracranial neoplasms, some number 6 or 6 to 10%. And the incidence, if you boil it down, is about 1.5 per 100,000 population cases per year, right? So in Ohio, which is about 12 million people, is about 150 new tumors a year. We actually see a little more than that, and these numbers change since we can all get MRIs pretty much in our lunch break now on every street corner, right? It's a lot more common to get MRIs, and they're ordered more frequently, I would say. So the incidence rate with that was probably higher than that. And again, what I mentioned earlier, there's sporadic tumors that are without a family history, really, they're not genetic, and the hereditary bilateral tumors that we will see with folks who have NF2-related schwannomatosis. Early symptoms are generally the smaller tumors. It's unilateral hearing loss, right, and then balance problems that are often transient, but sometimes can be more pesky problem, more permanent problem. Mostly it's this unspecific disequilibrium, like the sense of lack of balance. And then we have late signs. It's usually impaired facial sensation. So if the sensation of to touch in the face is impaired. And then brainstem compression, cerebellar signs are really coordination problems. Those are late signs, right? The problem is the unilateral hearing loss, if that's ignored as a first sign, right? For very small tumors, there's really no intermediate. There's no other symptom that would give rise to, hey, this tumor is growing, right? So we really should not ignore those early signs, because the late signs really indicate, again, a very large tumor already, and we certainly don't want to ignore those, right? So there's a long latency, often decades, between those early and late signs. Again, it's a slow-growing tumor. We should not ignore those early signs. And that's why our recommendation is for physicians with folks who have unilateral hearing loss to always get MRIs. Unfortunately, there's no other screening test that's accurate enough, right, and specific enough and sensitive enough, really, that would pick up these tumors. So we really are relegated to doing MRIs, right? When we get folks who have one of these tumors, so we do, we sit down, do a careful history and physical exam, a careful audiometric test evaluation, right, which is absolutely critical. And we test with hearing, and that's really important for this talk. We basically test the individual's ability to understand tones. So that's doesn't require a lot of brain power, obviously, and nerve power, really, I should say. So tonal hearing, right? That's the level of hearing. And then really important for acoustic tumors is the ability to understand spoken language, right? So speech audiometry, right? And again, these pure tones, when they don't match, that's very likely an acoustic tumor in play, meaning that folks can sometimes hear pretty well, but not understand what's being said, right? So that's classic sign for a nerve that really, again, can still transmit some sounds to the brain, but for more complex signals such as spoken language, it's really not very good. So, you know, it used to be that folks before MRIs again were on every street corner that ABR or BRs, which is a special type of hearing test that measures brain waves in response to sound, was used to screen folks for whether or not they have acoustic tumors. We don't use those anymore simply because it was not accurate enough, right, and sensitive enough. And in some folks with acoustic tumors who are really impaired by, their balance symptoms, right? And that's common actually in folks who have NF2. We do measure balance function. There's a VNG or ENG test, which is something some of you guys probably had. And there's a newer test called the Vestibular evoked myogenic potential. It's a mouthful. That's basically, it stands for VEMP testing, where we can often use these tests to hone in whether or not a smaller tumor takes its origin from one of the two balance nerves, right? That's really important for smaller tumors where we try to preserve hearing, right? And then, of course, MRI, and there are a lot of details on the MRI that we look for, that will help us determine whether or not this is a tumor that we will likely try to preserve hearing or try to preserve hearing at least, or something that we try to watch, right? So a lot of details on the MRI really beyond just the simple size of the tumor, right? We'll get to that in a minute. And then usually we classify the tumor based on hearing, right? So hearing is absolutely critical. Every tumor, we can't just, evaluate a patient with an acoustic tumor without knowing what the hearing is, because it's really going to affect our medical decision-making, not just in NF2-related schwannomatosis, but really also for sporadic tumors, right? So what's the hearing on the ipsilateral side? What's the hearing on the contralateral side? Always use that other side. And again, looking at that word discrimination scores, right? So that's the surrogate marker for clarity. We really always want to make sure what is the clarity, because that will determine whether or not that ear is what we call functional or non-functional. And this rule of thumb is that if your word discrimination score drops below 50%, it's very hard to utilize that ear, right? So we call it, actually, when the scores are below that, oftentimes we say that's really non-functional hearing. It's a little bit more complex than that, and certainly a little more detailed for each patient, but that's usually how, as providers, we think about this. And then balance symptoms are very important. How common are these? How persistent are these? Have they been present for a while, or is that just a transient phase that acoustic tumors cause some imbalance? Again, really important, because these balance symptoms really hamper the patient's ability, to function every day and their quality of life. And then, as I mentioned, some details of the MRI, the tumor size. That's usually the metric that patients or providers to throw out there, is have a 1 centimeter tumor, 2 centimeter tumors, but there's a lot more detail to that, right? And we actually did a study a number of years back that, we shouldn't just use the two-dimensional measure, we use the three-dimensional, but also we should use, the head size, for example, because it's all relative, right? And with NF2, of course, we want to know what other tumors are here. Again, really, really important, what does the other contralateral ear look like, right? Here are some kind of details of, examples of a small tumor here, a medium-sized tumor. So small tumor usually, less than a centimeter, medium-sized tumor, so 1.5 centimeters to about 2.5 centimeters, and then large tumors, anything above 2.5 centimeters. Where hearing preservation becomes very, very difficult. But again, we'll talk about some of the details. So you can see here this large tumor, extensively large tumor with compression of the brainstem. So it basically moves the brain out of the way, often to the other side. Of course, we have NF2, we would have one on the other side. Here, a classic medium-sized tumor extends into the cerebellopontine angle, so it may be touching the brainstem and the pons, but not necessarily impacting them. Right. And then an important metric for us is whether or not the tumor is growing. Right. It doesn't necessarily mean that the hearing will go along with the growth, but we do want to capture kind of the biology, the general gestalt of the biology of the tumor. So 70% of sporadic tumors that are confined to the canal. So the small tumor that I showed up here, right? These 70% of these tumors, statistically speaking, show no signs of growth or very little growth over, and then what's mentioned is always a certain period of time. It's usually a time over about 10 years, right? So a lot of intracranial tumors, right? Again, sporadic tumors especially, but also NF2, we feel very comfortable observing, right? So just watching it, getting MRIs in a year, and not really be too concerned about this. So that's this watch and wait rescanning option that I have on the slide. The problem again is that oftentimes, not always, but tumors that are radiographically stable, again, they look fine, they look unchanged on the MRI from year to year. They can cause progressive hearing loss over time, again, in the absence of tumor growth, right? And it's usually because the tumor keeps pushing against the nerve and the nerves it's like stepping on a cable, right? That cable becomes less and less thick and it really thins down, right? And oftentimes the true growth patterns are on two-dimensional. So we just look at the slice on the MRI, right? But these tumors are not just balls that are perfectly round, right? Oftentimes they are, but oftentimes they're not too. So oftentimes it's hard to capture the three-dimensional growth by just looking at two-dimensional image, right? So, and then the location is really important. Does the tumor just sit here? We use it this fluid here. That's the internal canal here. I hope you see my mouse pointer here, but you can see the tumor does not extend all the way towards the ear, right? So we call that fundal fluid. And that fundal fluid has been shown. Some studies actually have shown it really predicts our ability to preserve hearing. Some other studies have actually rebuked that. So we certainly, as surgeons, we like to see it, right? We like to see that the tumor does not push all the way against the ear, right? So there you can see this fluid cap here lateral to the tumor. So we definitely like that, right? So is the fundus of the internal canal clear that's fluid, right? Is the inner ear filled with tumor, right? Sometimes we do see with NF2, oftentimes hearing preservation is difficult if the tumor enters the inner ear, right? And then does the tumor basically over the years that it's been there erode into the temporal bone, so into the ear, right? So we do see that as well. Again, more commonly with folks who do have NF2. Right? Sorry about that. So we look at it as a surgeon. Again, I'm a surgeon. I look at these. Do I need to operate on this tumor? Do we send them to a radiation oncologist, or do we just observe the tumor, right? Generally speaking, small tumors, we can offer a middle cranial fossa approach, where we basically go from above the ear. We avoid the structures of the inner ear, right? That are depicted here in green. And by avoiding these structures, by not going through these structures, we can often preserve hearing, right? A translabyrinthine approach is a great approach. It's really safe for the brain. But however, we do go through the structures of the ear. So with the translabyrinthine approach, we are unable to preserve hearing every time, right? So translabyrinthine approaches are not suitable for hearing preservation. Sorry, my slides keeps skipping here. For a little larger tumors, usually a medium-sized tumor, oftentimes we use a retrosigmoid approach, which also allows us to avoid the structures of the inner ear, and therefore we can at least attempt to preserve hearing, right? So these three approaches in general, right, are our workhorses, how we can approach these tumors. And again, some of us allow us to preserve hearing, some of us do not allow us to preserve hearing, right? And again, specifically the middle cranial fossa, so coming from above the ear, is really only suited for smaller intracranial tumors. Usually we draw the line at about 1.5 centimeters, right? Those are the tumors. So they can peek out out of the canal, but not much. Again, smaller intracranial tumors are preferred. And there's an extended middle fossa approach, right, that we can use for some other tumors, such as meningiomas, or tumors that are quite maybe a little bigger than that, but really it's limited to smaller tumors, right? And folks with NF2, sometimes we use that approach not to remove tumors. So we want to, again, not give patient the risk of losing hearing. But again, we want to just take the bone off the top of the internal canal to basically decompress and give those tumors a little room to grow and breathe. And therefore, again, we avoid or delay that hearing loss that these tumors usually get by, again, compressing those nerves and pushing against them. We give them more room to breathe, right, essentially. So those would be an ISC, internal auditory canal decompression. That's definitely an option, right? And again, that retrosigmoid approach, again, all coming from all the way behind, panoramic exposures, extensive drilling, but it does allow us to preserve hearing. So those two approaches do allow us, at least in theory, to preserve hearing in, again, smaller tumors that are suitable for this, right? And then the translabyrinthine approach with which we use in a lot of tumors. And unfortunately, we do that because we can't preserve hearing in everyone, right? Is the translabyrinthine approach will basically go through the inner ear, right? The stuff that's shaded in green here. And it does allow us to sorry, I don't know why my computer keeps skipping, but it allows us to not push in the cerebellum. So it really is a nice, safe approach. But again, the disadvantage is it does not allow us to preserve hearing here. An important aspect with all these approaches and how we manage these tumors is really the facial nerve. And usually what we tell folks, facial nerve is always number one, right? In our mind as surgeons, we never want to round on someone who has a facial paralysis after surgery. The middle fossa is a little more technically challenging. Not every neurologist and neurosurgery team can offer this. It's very safe, but again, it does require a team that is really used to that approach, right? We do have to tug on the temporal lobe, again, above the ear on the left side where the dominant hemisphere is usually located. It can cause some temporary aphasia, meaning word finding difficulties in some folks. Again, it's we usually like to limit that approach to younger folks, right? And the facial nerve is basically when we view this tumor with a microscope intraoperatively, the tumor basically separates the facial nerve from us, right? So it's basically the facial nerve. Oh, I didn't say that right. The facial nerve can be right in between me as the surgeon and the tumor. So we usually have to move that facial nerve away from the tumor. Usually not a problem, but again, it does require a team that is really familiar with that approach. Again, translabyrinthine approach for a lot of neurologists is sort of the workhorse. It's the facial nerve is really right quite easily to be found, and again, it's in normal anatomic position, so we don't have to basically find it between the brainstem and the tumor, right? In the retrosigmoid approach, typically the classic neurosurgical approach, where the facial nerve has to be found basically when it enters the brainstem, right? So in that zone, that's a little more difficult than finding it again, or into when it comes out of the bone. And then a few terms that we should talk about is the gross total resection or complete resection, right? So there was a trend about 15 years ago where more and more of these tumors were found to have an incomplete resection, where it was safer to do an incomplete resection, meaning leave tumor behind, right? And there's certainly, and still to date, a trend to preserve function rather than obtaining a complete resection, so gross total resection, right? So often leaving a sheath of tumor, like a veil of tumor, that protects the facial nerve, right? So you have complete resection, subtotal resection, near total resections. And near total would be just leave a sliver of tumor on the nerve that's usually cut off from all the blood supply. So usually we can't even see that on the MRI. So the goal here is really to preserve the facial nerve, right? In NF2, it reverses a little bit, where the facial nerve is also very important, obviously, but hearing preservation really comes to the forefront. Hearing preservation for us in schwannomatosis, in NF2-related schwannomatosis, hearing preservation is absolutely critical. And important when we tackle these tumors to understand, especially with hearing preservation or attempted hearing preservation, that we ensure this is actually an acoustic tumor, right? Because if it's something else, we may not be able to preserve hearing, period, right? Or we may not want to operate. So a lipoma, right? Lipoma is basically adipose tissue. So those are fat cells, right? So you can see here, there's an MRI without fat suppression, where the cheek fat here looks exactly like the tumor, and we can actually suppress that on the MRI. There's certain sequences we can do that can help us figure it out. So certainly a lipoma would not allow us to preserve hearing, right? Because it looks like a nerve. So on lipomas, we strictly avoid surgery at all costs, really, right? So we never operate on a lipoma. And then a meningioma, so we did one of these yesterday. So meningiomas are often much harder for us to preserve hearing, right? So they look a little different. They can really mimic acoustic tumor. And 6% of all acoustic tumors are thought to be actually, when we go in, are actually meningioma. So sometimes it's a little harder to tell the difference between the two, and then there are other tumors that can be in that area, such as metastases and the like. So that being said, most of these tumors in that general area are acoustic tumors, and of course with NF2 we would expect these to be acoustic tumors. Another really important factor for hearing preservation, but also for picking a basically approach for management is whether or not these tumors have cysts in them, right? These cystic parts of the tumors are thought to be intratumoral hemorrhage. So basically that the tumor did show some bleeding in its core, right? And once that blood goes away, it leaves a cyst. So these tumors are considered less ideal for radiation. The reason for that is these cystic lesions, when we radiate basically water in that area, it would swell quite dramatically. And especially if you'd like to preserve hearing, you don't like this acute swelling or this acute increase in size of these tumors because that would kill hearing. But it can also harm the facial nerve and other surrounding structures. So again, these cystic tumors are considered less adequate for radiation, as I put on the slides here. And we usually would prefer surgical management, although, observing these tumors, meaning watchful, waiting, would be also considered something that we feel is adequate. And then balance function, again, this disequilibrium, we often see this with small schwannomas. We really don't see that with bigger tumors much because people have probably gone through that process of where the vestibular nerve is already damaged enough where it can't really do more damage, right? In folks who have really persistent disequilibrium, we usually try to remove these tumors, especially with older folks. There are some other options, such as gentamicin, which is basically an antibiotic. That's kind of a poison to these hair cells in the ear, and that we inject into the middle ear that then we could manage the patient's dizziness and balance functions, basically non-surgical. And then, of course, a first line of treatment is really always going to be vestibular physical therapy, where we basically ask folks to meet with a physical therapist. Sometimes that can be done at home as well, but at least go to some sessions, be evaluated. And that's usually, a lot of my patients are really skeptical about it, right? Feel like it's a little voodoo, but it does actually work. So vestibular physical therapy is certainly a good first line of treatment that we'd like to again promote. And then going back to hearing preservation. So again, it's theoretically possible with a middle fossa approach, a retrosigmoid approach. Again, translabyrinthine approach do not allow us to preserve hearing. And hearing preservation, it's typically either all there after surgery or all gone. It's not entirely true. There are some patients who have preserved some hearing, but it's not all gone. But in generally speaking, it's either all there or all gone. But it depends on the integrity of the labyrinth, right? That we don't drill into the inner ear, that we preserve the blood supply to the inner ear, and most importantly, to preserve the hearing nerve, right? Again, facial nerve and sporadic tumors is generally more important. But I'm a hearing doctor, right? I want you to hear. I want you to preserve your hearing. So preservation of that nerve is really absolutely critical. But again, we not just have to preserve the nerve, we also have to preserve the blood supply to the inner ear, because that inner ear basically is where the sound information that's hosted in a traveling wave, so in sound information that we know from acoustic waves that are then transmitted into electrical signal in the inner ear. So we need that inner ear, even though the inner ear may be totally fine, we need that inner ear and the nerve in order for the brain to hear, right? So all these things need to happen for us to preserve hearing, right? And I put that on this slide again. It's typically they're all there, all gone. Again, it's not all 100%. And oftentimes, we have the safety decision of the translabyrinthine approach, which generally viewed as a very safe way to remove these tumors versus attempt to preserve hearing, right? So oftentimes, again, weighing that with the other options such as radiation as well as just watching it, right, is really kind of key. So I'm not a radiation oncologist, but I do want to say a few words on stereotactic radiosurgery, which is really not surgery, it's still radiation, right? But it's radiation and hearing preservation, right? Because that's oftentimes is radiosurgery is used as a way to preserve hearing, which we disagree with, right? So usually it's a gamma knife or cyber knife. There's a lot of marketing out in the community, obviously, for these modalities. We have a gamma knife here at Ohio State. We use that. A cyber knife would be an equally effective device. There are newer devices where you don't have to have a head frame. So if you're claustrophobic, such as myself, there are ways to get this kind of treatment. Patients were first done in the late 60s, but really thousands of patients have gone through it. It's generally safe. There are long-term effects that are really unknown. But really, if you look at the literature, it does not preserve hearing, right? So the well-done studies that are done with actual hearing tests, show that after 5 to 10 years, really the hearing is mostly gone, right? It's just a slower process. That being said, we had folks who had hearing, go right after radiation, so immediately after, right? So it does cause some temporary swelling of the tumor, right? Which is one aspect of why people lose hearing. I also want to make sure that folks understand this radiation is something that we offer for sporadic tumors. We're really, really hesitant of offering radiosurgery for folks who have NF2, right? And the reason for that is if you have a tumor suppressor gene issue, which is the reason folks have NF2, radiation can cause some what we call a malignant transformation and some other problems. And I'm dealing with a case right now where someone was radiated somewhere else and they have a malignant transformed tumor, which is almost fatal, essentially, right? So we want to make sure that the biology of the tumor, and if you have NF2, is very different. And I wouldn't say I've never rated someone with NF2, but we're very, very hesitant, right? So again, think of that. I think the malignant transformation potential overall is very low. If you have NF2, it's probably a lot higher. And we're worried about this continued growth after radiation. And we're also worried about the marketing kind of message that radiation preserves hearing, which may be true for the very, very short term, but in the long run, it's really not the case. So durable hearing preservation versus short-term hearing preservation. And then, of course, a few words. Sorry, for some reason, my slides don't advance here. So NF2, as we all know, 2 acoustic tumors, some other growths as well as meningiomas, etc. Here in this picture, depicted here with 2 acoustic tumors. There's some other tumors here in this area of lower cranial nerve schwannomas, trigeminal schwannomas. So classic presentation for NF2. Certainly in this scenario, how do we go about decision making? Oftentimes a lot more complex than with sporadic tumors. But most folks with a sporadic tumor have a normal hearing and normal ear on the other side, right? So with this, obviously, our primary goal in NF2 is really to preserve hearing for the longest period of time, right? I mean, if I had to pick one kind of paradigm that we use or one kind of mission in patients with NF2, it's the most hearing for the longest period of time, right? And again, acoustic tumors in 90 to 95% of those who have NF2 Again, the new terminology is NF2-related schwannomatosis, right? We listed all the symptoms here. You're all familiar with that. And there's substantial variability in how folks present. Everyone's different. The biology of NF2 can be very, very different with kind of the level of aggressiveness when folks present in their life. Usually is a surrogate marker for that level of kind of aggressiveness. How fast these tumors grow, what other disabilities, and kind of spinal tumors and all that. But oftentimes those acoustic tumors are the most significant medical issue, at least early on in that NF2 journey, right? And oftentimes that decision and that hearing preserving decision takes center stage for us and the patient, of course. So management of acoustic tumors from a surgeon's perspective, I can tell you that observation is by far the most common one, right? Especially early on, right? Very large tumors are really not candidate for hearing preservation, right? Unfortunately, right? So sometimes even larger tumors that would exceed kind of the threshold that we want to watch a tumor if you have a sporadic tumor rather than NF2, we would a threshold for watching it is much higher, right? So we would be okay observing tumors as long as there's some hearing there, right? For small tumors, in an only hearing ear, we would offer to decompress the IC. That really mitigates or really limits that risk of hearing loss from surgery. But again, the goal of long-term hearing preservation would be fostered by just decompressing that bone and giving the tumor a little room to grow. So that decompression is really a reasonable thing. If you have a tumor that's really small, patient has good hearing, NF2, and we do some vestibular testing, and we're really pretty sure the tumor comes from that supravestibular nerve, which really enhances our ability to preserve hearing, right? In those cases, we would offer a middle fossa. Again, if it's really a solitary small tumor, it comes from the supravestibular nerve, we'd be okay with offering that middle fossa removal, because that would give the patient a real good chance for durable hearing preservation, because we took care of that tumor, right? So early surgical intervention, as opposed to if the tumor is really small with the middle fossa, typically, as opposed to delaying tumor removal after hearing has been lost, really, right? So from a surgical perspective, that's how we're looking at it, right? Obviously, with the new biologics, right, Avastin really kicked that off, but there's some other ones on here. Again, I'm not a neuro-oncologist, but those have really, really helped us. And we rarely operate on teenagers anymore, just because we have these other options where we basically, buy people time and us time. So that's really helped us, right? But if there is a tumor that's growing where hearing is gone, we may still recommend a surgical removal and then placement of an ABI, right? The other option is it's a newer option that we actually offer cochlear implants, right? So we'll talk about that in the next few slides here. And again, observation, I'm going to run through this real quick. The most common treatment options: small tumors, only hearing ear, right? Bilateral tumors, they're too large for hearing preservation. Again, 2.5 centimeters would be really the cutoff, where the data has really shown that it's really hard to preserve hearing, even with a retrosigmoid approach. Again, once the tumor is beyond 2.5 centimeters, right? If it's a new diagnosis, a fresh diagnosis, right, we would get MRIs usually 6 months apart. If it's an established diagnosis where we just observe tumors, where we know kind of gauge growth rate, we would usually be comfortable getting MRIs once a year. But again, that initial one, we want to make sure we capture these. They're rare, but we do see them periodically, tumors that really have a higher growth rate, right? So we want to make sure that we understand what we're dealing with. And then, of course, consider surgery with life-threatening complications, right? If the tumor really is very large, pushes against the brainstem, really what we call hydrocephalus, right? The cerebrospinal fluid cannot circulate properly, right? And again, tumors that have life-threatening complications and/or are excessively large, without hearing, or really with unserviceable hearing, again, when the understandability score drops below 50%, really we feel like it's reasonable to consider taking a tumor out, right? And again, with NF2, the control rates are worse, right? And we're worried about, again, malignant transformation that I put on here. We also have seen folks that get radiated and then have it show an accelerated growth afterwards, right? Again, due to the inactivated, again, it's the biology of the tumor, due to the inactivated tumor suppressor gene that's part of NF2. And then of complications, of course, with, again, radionecrosis, cystic formation of these tumors. They can swell quite a bit and can swell for up to 2 years after surgery. I've even seen them swell a little more. And again, we're always careful with more aggressive NF2 versions like the Wishart phenotype, as opposed to the Gardner phenotype, where, we see large tumors that are rapidly progressing. We really are not big fans of offering radiation. Again, have we done it? Yes. But in NF2, we're really hesitant of offering that as an option. Again, and one option is, again, that early surgical, either you operate really early or really late, I guess is what I would say, an early surgical intervention with attempted hearing preservation, right, as opposed to delaying surgery, as I put on the slide, and consider the decompression as well, and what the other side looks like. So oftentimes the decision making, there are a lot of factors involved, and usually we need to sit together, stick our heads together, and really come up with a solution. Together with the patient and their family, what's considered, a reasonable option, right? And again, these multiple considerations. Doesn't look like it many variables, but when you sit down and really boil it down, it's usually quite complex of a discussion. And then again, gross total resection at GTR means gross total resection, hearing preservation rates. Again, for a middle fossa, if that's an infravestibular nerve tumor, the hearing preservation rates are as low as 38% and as high as 70%, right? The decompression, on the other hand, is something, again, we almost exclusively use in NF2, really allows the tumor to grow and they give it room to grow in this confined space. Recurrence rates, again, that's an important aspect, are definitely higher in NF2 compared to sporadic vestibular schwannomas. And tumors are likely, grow from different nerves. And we've seen tumors, we have single nerves grow multiple tumors, right? More aggressive growth patterns. And, just being cognizant of all this in NF2 is really critical, right? Maybe a few words on a retrosigmoid approach is a good approach. Again, usually 1.5 to 2.5 centimeters with preserved hearing, with functional hearing, right? Hearing preservation is usually a lot more difficult than preserving the facial nerve. In some cases, however, the hearing nerves, we call it the cochlear nerve, can really be out of the way, and it's easier than we think. But it's definitely not the norm, right? So retrosigmoid approach, what allows to preserve hearing, we still need to, preserve the nerve, preserve the blood supply, and preserve the integrity of the labyrinth to make that happen. So a lot of things need to happen for us to preserve hearing successfully. I think the most important thing is to work with our medical oncologist, neuro-oncologist, and really use these biologics. Again, Avastin, bevacizumab was the first drug. There are some other newer drugs that I put on the slide here. Again, I'm not an expert on this. I'm not a neuro-oncologist. But I can tell you that Avastin and, again, some other drugs have really changed our ability, and it's really changed our field quite a bit, and it gives us other tools to, again, delay hearing loss and help people in the long run, right? So it's really, I can tell you that right now, that we don't try not to operate on a lot of teenagers anymore. Just because we have this in a back pocket, right? And then again, that's the Dr. Plotkin, who many of you know, I'm sure. That was his paper from over 10 years ago, really a pivotal paper. We show not only can we shrink the tumor, again, the primary indication really for bevacizumab is not necessarily to shrink the tumor, but it's really to preserve hearing, right? That's what we use it at. Right, we use it as a hearing preservation treatment, again, together with our medical oncologist, right? So those are some details from that paper. Came out in the New England Journal of Medicine, very prestigious medicine. I would say it was one of the most impactful papers of the last decade or two, right? And then response rate is about 53%, 70% control. You know, despite that, some tumors show some progression, and some tumors will require surgery, even being on bevacizumab, right? That's important, that it doesn't work every time, but again, a lot of times it allows us to delay hearing loss over a significant period of time. And 54% of patients have no tumor growth, it's really stable disease, right? Have no 60 some percent have no further hearing loss. And again, some patients have really a positive hearing response, right? Where they really move up a hearing class. And the way these were classified is if you move up a class, you may go from non-functional hearing to functional hearing, where you can talk on the phone, where you go to a restaurant, right? So it's really kind of a significant benefit for patients. Unfortunately, hearing loss is most inevitable, at least on one side, right? It's usually the ongoing damage to one of the cranial nerves, so the cochlear nerve, really, right? Our goal is really to improve the patient's ability to function, to enhance the quality of life. It's important to hear, obviously. It's the way we communicate. Usually it's the hearing aid, right? So many folks have to have some hearing loss, but hearing is still functional, can benefit from a hearing aid. That's usually our first line of treatment, right? In order to benefit from a hearing aid, you need to have functional hearing. So you need to be able to understand spoken language, right? And then if that's not possible, we've used cochlear implants more and more. And again, a cochlear implant is really similar to a brainstem implant, but a cochlear implant is more successful in that it that provides really reliable improvement in hearing, and especially reliable improvement of the patient's ability to understand spoken language, right? So it's all about that. It's all about the clarity of the signal, right? And then an auditory brainstem implant is an implant. It's like a cochlear implant, right? It's basically the same device that has a slightly different electrode that's placed on the brainstem, right? So it's designed for folks who have NF2. It's FDA approved for 12 and up, 12 and over. These are kind of what the labeling of with the FDA, the terminology shows. So it's basically a modified cochlear implant that has an electrode that's a ground electrode that goes into the temporalis muscle, so chewing muscle, and then there's an electrode that's put on the brainstem, basically in that foramen of Luschka, where we get close to that first center in the brainstem that processes sound, basically. Again, it does not work as well as a cochlear implant, right? There's some patients who do quite well with it. There's some patients with NF2 who are unable to use it. So it really depends on what stage it's done. It also sometimes folks were surprised, to get a lot of benefit from these where we didn't think so. Usually it's done together with the tumor removal, so at the same time, right? We'll remove a tumor, and one study has shown that it's the more patients have more and more benefit, the smaller the tumor, right? So sometimes if the hearing is gone on that side, we would offer a brainstem implant earlier rather than later. Even if the other side has some hearing, we call that a sleeper implant, just to get that implant in before the tumor starts deforming that area of the brainstem, but just haven't been there for a decade or so. And again, implantation at first or second tumor removal, right? That's pretty much what I mentioned. We can sometimes implant, some folks don't want just us to get the tumor out, and if the other side's still good, and we've gone back sometimes and implant folks who had previously tumor removed, that's fine, it's not a problem. But again, we do prefer getting it in as we implant, as we remove the first tumor. Again, those would be considered sleeper implants, right? And again, that may enhance performance when all hearing is lost on the other side, right? This is the electrode. It has these 22 little dots here. Those are little individual electrodes. And in the operating room, we usually program these so the patient can hear. And then when we talk about the ABI outcomes, again, they're highly variable, right? If possible, we always prefer to do a cochlear implant. But again, the cochlear implant relies on the viability of that nerve, right? We need a really good nerve to work with for a cochlear implant to work. So it's a little lower levels of performance than multi-channel cochlear implants. 80%, if you look at literature as daily users, right, they may get some sound awareness where you can hear that someone's talking, but you don't necessarily can understand all the words, right? And 92% receive auditory sensation. You see, but for some folks, it's not enough to warrant wearing it every day, right? And again, that sound awareness, and it aids usually in lip reading. And open set, basically, when you don't know what's being said and you can decipher that, right? That would be considered open set speech discrimination. Remains a challenge. Usually only is achieved in it's like 20 to 25% of folks where they can really understand what's being said without having a context, right? So I think I'm at the end here. It leaves us some time for questions. So as we all know, NF2 is really complex. The decision making is really complex, and really having a team, having a care team for patients, I think that's kind of the most important advice I can give you is to have a team that's used to dealing with NF2 that really knows it can can somewhat take your position and say, hey, this is usually what folks have told me it's important to them. This is how do you feel about this kind of stuff? Having that experience in my experience really has been critical, at least, when I meet with NF2 patients and I talk about, you know, what they want me to help them with, right? And what tools we have available. We need a good neuro-oncology team. I can't just do it alone, right? I need a good neurosurgeon. I need a good neuro-oncology team. We need a good radiation oncology. We need sort of a real team. You need that village, that takes care of you, right? Again, this patient care team is absolutely critical, I think. And management of acoustic tumors, even if it's sporadic, is often complicated, right? And with NF2-related schwannomatosis, it's exponentially upon exponentially more complicated, and you need that care team and get second opinions, and inform yourself what you're doing right now by listening to me, I guess, and just having CTF with their resources behind you, I think is absolutely critical. And again, thanks, Kate, for allowing me to talk here in the CTF. Thanks for listening. Happy to take questions. Here's my email if anyone wants to reach out directly. So no one else will reach my email. So if you want to reach out, if you want me to connect you locally or whatever it is, really, any feedbacks, greatly appreciated. Happy to take questions. And again, thanks for listening.
Thank you so much, Oliver. And so kind of you to share your email with the community. I'm sure that will be really appreciated. You did such a lovely job. We actually had a few questions come in that you covered as you were speaking, but there was one from Sally that I thought was interesting, kind of going back to when you were talking about surgical approaches. And the question was whether the middle fossa approach that is, so I'm just going to read the question. It says, does the middle fossa approach that is just used for decompression have the same risks to the facial nerve?
No.
Okay.
It does not, right? So a decompression is, if it's done right, and if the team, the neurologist and neurosurgeons really know what they're doing, the risk is extraordinarily low, right? So that's I wouldn't really, even the hearing loss risk is not zero, or nothing zero, right? Unfortunately, in medicine, but surgery, but we would actually only engage that or recommend that approach if we really want to get that risk for hearing loss really almost to zero, right? Similar to facial nerve would be the same, right?
Yeah, no, that's helpful. And then I know I heard you talk about this, but just because as someone who gets this question a lot from families, I thought it might be helpful to revisit it for a moment, in that the given the concerns around that you talked about around radiation therapy, and particularly around some of the messaging being a little misleading in its role about preserving hearing, what would you recommend to someone who is an NF2 patient or is the parent or caregiver for someone, and maybe the doctors they're seeing are recommending that or are kind of saying this is a good option? How would you recommend families handle that?
Yeah, I would go back to the care team, right? I would say, hey, where's the neurologist? Where's the rest of the team? Is that something that's um we don't want the lone wolf decision, right? And I don't do those either, right? I mean, I have a team behind me, right? When I make a decision, I have people, check on me is probably the wrong word, but maybe there's another opinion out there that I haven't thought about, right? So these are critical decisions that are life-changing for a lot of patients, right? I don't take these lightly, nor should anyone else. And if something's recommended where you're like, I'm not sure, just get a second opinion, right?
Yeah.
And I think that's what I would do. Radiation, just a few words. As a surgeon, I get it. No one wants to have surgery. And surgery comes with risk, especially if you're NF2. I completely get it, right? Um, we just really want the best for you, right? I don't want to do surgery on you if you come back and there's a problem, right? I mean, that makes me look, that's just not, I go to work and trying to help people, right? Not the opposite, right? Obviously. And it's like, oftentimes, I feel like radiation oncologists don't have that follow-up, right? They don't really, a lot of these studies, they claim to have hearing preservation, but no one actually did a hearing test, right? So how
Mhm.
can you claim that, right? So it's really critical to have to use real data and not just kind of marketing data used for decision making. And I think that's with NF2, we're just really, really careful with recommending radiation, right? With sporadic tumors is a lot different, right? But with NF2, we're just because of that biology, we're just hesitant.
Yeah, no, that's really helpful. I did see that while we were chatting, several new questions came in. So I want to
Yeah,
assure
yeah.
everyone who's joined us today, since we are almost at time, that I will make sure those questions get to Dr. Adunka, and we will make sure that you get some kind of response or some information for those things as much as possible, just so we kind of respect everyone's time today. But they're great questions, and we're so thrilled that everyone was here to join us. So thank you again to Dr. Adunka. I am going to just do some quick housekeeping so that we can close up shop for today. But thank you for being here. If you enjoyed today's presentation, I have some great upcoming opportunities for you to consider. So first is our annual NF Summit, which is CTF's gathering it's an in-person gathering for families and individuals impacted by any type of NF. And that's going to be in Washington, D.C., June 19th to the 21st. And we would love to see you there. And all of this information will go in the chat as well with helpful links. A little sooner than that, on May 22nd, in honor of NF2-related Schwannomatosis Awareness Day, we'll be hosting a special webinar where you're going to hear from CTF scientists, from Dr. Bacher and Dr. Nievo, talking about the way that CTF is specifically funding and driving breakthrough research in this field to change the future for this community. Registration information for that webinar will also be in the chat. And then this series itself, the NF Knowledge series, this happens every month, sometimes twice a month, with a list of all kinds of topics, sometimes that are relevant to the entire NF community. Other times, like today, it's specific to one set of diagnosis. So the link to the calendar to see those upcoming topics will also be available in the chat. And if that's too much in the chat, then please consider signing up for our newsletter, which will make sure that all of this information is coming right to you in your inbox via email, so that you don't miss out on anything that we are doing and things that are happening and exciting news coming out in the world of research and clinical care for NF and NF2-related schwannomatosis. So thank you again to Dr. Adunka for being here today and for everyone who joined us. I hope you have a wonderful day and enjoy the rest of your week. And I hope we see you next time. Thanks, everyone. Bye-bye.